So positional plagiocephaly. When we talk about positional plagiocephaly, what we mean by it is the flattening of one area of an infant's skull caused by prolonged pressure on the same part of the head. Okay, and it's sometimes called flathead syndrome. So newborns have very soft skull, right? It's very soft. It takes time before it gets fully ossified. So when they lie on one side for very long time, they can get something we call positional plagiocephaly. And let's look at the causes here. We are saying frequent sleeping in the same position. That is one. Limited tummy time while awake. Tummy time is like putting a patient on the tummy. The patient lying down on the tummy. That's what we mean by tummy time, right? On the stomach. All right. Or on the abdomen. All right. Then we have something we call torticollis. Torticollis is one of those things that can also cause it's one of those things that can cause positional plagiocephaly. And especially our midwives here, I hope you have heard torticollis before, right? An issue with your neck muscle, the sternocleidomastoid muscle, right? It's arises from your sternum, okay, then to your shoulder bone, right? Then it goes over your mastoid process. The mastoid process is like think your cheek, around your cheek or your jaw, that side. So the muscle, we have a bundle of muscles that make up the neck muscle, right? So sternocleidomastoid muscle is one major one. When you have issues with it, okay, it's in particular that's what is being affected, right? And that is where um when like your chin points, okay, towards one side due to like your neck muscles being stiffening. I mean this sternocleidomastoid muscles I'm talking about. Okay, let me use the word neck muscle so that it will be easier for you. So you have when you see these people with these torticollis, you have the chin, um, the chin and the head. Okay, the whole head and the chin. The head moves with the chin anyway, pointing to one side. Okay, due to the tightening of the neck muscles we're talking about. So they're always tilted on one side, right? Okay. We have different areas where you can meet particularly. So I think midwives in bed, right? Like some bed defects and all of that. Yeah. But we're not going deep into that one. Just the torticollis is what we are trying to talk about. Then prematurity. Okay. Um, so you can have newborns, premature newborns who will be um, very exposed to this one, okay, or who will be what's the right way to use here? Who will be susceptible, yeah, to this condition because they have softer skull bones, okay, because of prematurity. So these are some of the causes of positional plagiocephaly. And let's look at some assessment findings. What you find among these people. They have flattened area on the back or side of the head. So depend on which part of the head that lies or that comes in contact with uh, where he or she is lying. That place becomes flattened. Okay. Then there is um, asymmetrical head shape. Of course, when one side is being flattened, the whole head is going to be asymmetrical. Forward displacement of the ear or the flattened side. Okay, that one to the end. So this one has something to do with just the shape of the head. It doesn't affect anything like neurologically. So it doesn't have neurological deficit, just the shape of the head. Okay. And they will have normal head growth and development. They will have a normal one, but it's just the shape. Okay, because they have softer bone or softer scalp, right? That is it. And how do you manage these people? How do you manage them? So we are saying increase supervised tummy time while awake. So normally you are supposed to put babies on their back when they are lying. Okay, when you put them or when you turn them upside down, like on their tummy like this, okay, for this, for the prevention of this condition, what is likely to happen if it's not supervised? When you give babies tummy time and it's not supervised, what is likely to happen? Can tell us.
They can block their nose with something around like a bedsheet cloth.
There's a term for this whole thing. Can you
Um,
mention it?
okay.
I think it's sudden baby death syndrome.
Sudden infant death, SID. Okay, so when you meet SID anywhere or sudden infant death syndrome, yeah, maybe you can add this. But sudden infant death, these are some of the things that can cause sudden infant death. Okay, that is why. So when you are reading, be careful of the wording. Okay, anytime they go on their tummy, it should be supervised. Okay, to prevent sudden infant. You are trying to prevent something from happening to your baby, but you don't want your baby dead, right? It is very, very important. They know these babies, they can't tend themselves. Okay. Unless you tend them, they can't rule and all of that. So you have to give you have to increase supervised family time. Jacob, do you want to tell us something? Keep on unmuting. And your background is a bit noisy. All right. Then the next one, alternate the infant's head position during sleep. Okay, so it's like you do manual turning of the head so that one side does not lie for a very long time. Okay. The next one is reposition toys and stimuli to encourage turning the head. Okay, so um, if they are getting to a stage where they can maybe try and turn their head, you also try and reposition toys. And if you are taking them like any stimuli you encourage, you try and make sure it's not only on one side. Okay, you change positions. Then you treat torticollis with stretching exercises or physical therapy. Okay. Yeah, when it's seen earlier and it's been dealt with at a younger age, especially at the younger stage of the baby, it gets better. But when the muscles grow and they become stronger, it will be there forever. You know, so that is one thing. Then severe cases may require a cranial molding helmet. So this is the worst case scenario. Okay, like among all the management, and you will not wait until you get to the last point. Yeah. Any question on this slide before we carry on? Okay. Now prevention, like we said, continue back to sleep for safe sleep. This back to sleep you're talking about, like lying on the back, that's what you mean. That's why it's been bolded. Okay. Provide frequent tummy time when awake and also supervise. We thought about that already. Change the infant position during feeding, even when feeding, and play. All right. And we have another condition we call craniosynostosis. So craniosynostosis is different from positional plagiocephaly. Okay, then craniosynostosis has something to do with the sutures, yeah, the sutures. Okay, when they become fibrosed and hardened earlier than it should be. Okay, and that also can make the head shape deformed. Positional plagiocephaly can deform the shape of the head, and craniosynostosis can also deform the shape of the head. So this is just to let you know they are different. This one is because the sutures becomes when hardened, like should I say fibrosed, okay, or hardened. It's hardens faster than it should be. Okay, so it makes the head assume different shape, a shape that you don't want. All right. Think we are being abstract on all of these things. Let me try and show you something here. Um, Look at this one. So look at this side. On my right hand side here. Um, you see that the skull has been deformed, okay, and the shape of the head has been deformed, okay, because you had the let me see if I can get you. Okay, so you see in a physical picture of an individual, this is what you will see. You see how the head shape will be like. You see the forehead. I don't know how I can make this one bigger, even bigger. Yeah. Have you seen the shapes we have here? These are real pictures. You see the shape of the head. So these are cranial synostosis, right? So that is what we have. When you have premature fusion of the scalp, okay. So instead of the sutures to take time, okay, and get fused, they get fused earlier, and they assume different shapes, okay, and that is what you will see in the physical picture, okay. And when it's worsened, maybe it has to be corrected. You have to go in for a surgery depending on what is really happening, right? So this one also causes a change of the shape of the head, but it's different from what we are talking about. Um, I think it's even here, plagiocephaly. So you see how it is. Look at this one where I'm set. Okay, so let me hit it. You see, this is a real picture. You see how it is positional plagiocephaly. And so that side line, you see it's becoming flattened, right? Look at the picture down. After this baby is being raised, you see how the occiput looks like. Not every baby will show that, but it's common. So you can see we have a lot of pictures here like that. So that is positional plagiocephaly. Any question? Okay. All right. So a quick memory, even if you forget about anything, try not to forget about this. Back to sleep,
Please,
submit to
can you
sleep.
go back to the previous slide?
You want to ask a question over here?
No, thank you.
Okay. So back to sleep, tummy to play. What it means is when you want to make them sleep, okay, let them lie on their back to prevent what? Can we all say it?
Sudden infant death.
Sudden infant
Sudden
death
infant death.
syndrome.
Good. And when they are awake, whilst we are with them, they can do what? They can have a tummy time to play, okay? And that is when we are with them and we are supervising them, right? So that you don't have anything. When they are tired to, some of them will try to lift up their head whilst on their tummy. When they are tired, they might try to lie their head, and it can be, I mean, their nostrils can be obstructed by anything. So that is why it should be supervised. All right. So you are saying tummy time while awake prevents plagiocephaly and strengthens the neck muscles too. Your sternocleidomastoid muscle. Right. Any question? If no question, I have quick questions for you. For those few things we were discussing the last time, then this one, let's see. There are not too many, but let's see if you can get a reader and go through them quickly. Any reader?
I'll read. A nurse
Okay.
is teaching the patient, sorry, a nurse is teaching the parents of a kid with strabismus. Which of the following should be included in the teaching? Your kid
So
should
this
be,
one, we're not doing strabismus, but I was like, when I saw this question, I was like, let me just bring it in and see. We have eye conditions that I mean, the things are plenty. We can't touch on them, but I just wanted us to draw attention to something here. That's why I brought this question. Okay. All right. So who can try?
okay.
Who wants to try? Strabismus teaching. Unless you don't know strabismus. Strabismus teaching. Those people who will be looking at you as if they are looking somewhere.
The answer is
Hey,
three.
the answer is what?
The option three. I think I read somewhere in the rationale was like if you put a patch over their strong eye to make them use the affected eye to strengthen the muscle over there. I don't know whether I'm right.
Okay, 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 okay. Yes, any other answer? Any other answer? So in short, do we cover the stronger or the lazy eye? Which one do we cover? Especially during the eye patching. Yes, of course, as part of treatment of strabismus among infants, we do eye patching. Okay, those of you who don't know eye patching, it's like we cover one eye. So the question is, which eye? This is a very intelligent and English question. I think
We
it's in
we
most of
we cover the strong
children.
one.
The
The
strong eye.
strong one.
Yes, you cover the strong one so that you give chance to the lazy eye, okay, to try and focus. You see, it's like trying to tell the lazy dude to get to work. So that's how you remember. Like you, the strong guy, just relax. Let us see how well the lazy guy does. Okay. So that is it. So always take note of this one. Okay. So you can have different ways, different ways of strabismus, right? Some can point inwards, some can point outwards, and the rest. Yeah. So at the end of the day, when you are patching, you have to patch the stronger eye. That is correct anyway. All right, let's look at our rationale. Yes. So if this is your first time of hearing about strabismus, if this is the first time of hearing about strabismus, that is strabismus for you. This one, surely you shall meet it somewhere. If you haven't even met it already, look at that. You see how strabismus is looking somewhere, right?
Yeah, misalignment.
Yeah, I'm just saying it literally. I'm making mine somewhere, right? All right. So that's strabismus for you. Okay, so we have those pointing inwards, outwards, upwards, downwards, and all right.
But yeah,
Yes, sister.
please, can you share with us what causes the strabismus?
People are born with it.
Yes, I
People,
know people are born with
mm,
it, but is it because
so
is it uh-huh.
uh-huh. Okay, so most of the times with children, okay, because we are doing pediatrics, let me talk about that of children. Even adults, we have some people who are born without strabismus and later get strabismus, but I'll talk about that one later. Let me talk about with the children. With the children, some come like that. I mean, it's congenital, okay, and I think
Mm,
it's is it I've forgotten the muzzle, but it's one of the eye muzzles. I don't know whether it's rectus muzzle. Please, I'm not sure about the muzzle type, right?
mm.
Yeah, but it's one of these muzzles. So it could be because of if you have family history, apart from being congenital, if you have family history too, you can get I mean the child can get if it's in the family. Okay, and there are some of them, those of us here who are eye nurses and they are trying to hide. I think refractive errors too can do that. You know, those ones that require glasses, right? Corrections, glasses to correct them. So refractive errors too can also cause strabismus. With adults, when you get any
Okay.
severe brain injury, like stroke, trauma, or any brain injury, you can even get strabismus, meanwhile you were not born with it. Okay, so these are some of the things that can cause strabismus. I don't know if I've been able to
Um
help. Yeah.
I I wanted to find out, does the birthing process, the child passing through the birth canal, have any influence on, or is it possible that that process can cause a child to have strabismus?
Birth process, that one I am not sure. Well, I'm not saying yes or no, but I haven't taken my time to read about that. If anyone knows here, the person
Okay.
can share with us. Because I'm just looking at anything is possible, though, but I can't. It's something that I've not seen. I can say yes or no. If someone have seen it somewhere, the person can share it with us all here. Our midwives here thinking about birth, strabismus. Can the eye muscles be affected during birth? I know particularly it's one thing that it can, I mean, birth accident, can cause that. But with the eye, anyone who can help us, well,
Sir, please, when you
it,
Google, it
it
says muscle or nerve dysfunction.
okay, okay. So, a nerve can be, I mean, you can have a nerve accident, right? Well, maybe we should all search because I can't say it exactly and which the person is giving which type of nerve. Um, unless we look into it, right? But what I know is that it's congenital, people with family history, and refractive errors for children. These are the things that I can say yes. Yeah, but anyone who has found anything?
Yes, it says that the birthing process can cause strabismus,
Oh,
but
okay.
it is relatively uncommon and typically
Yeah.
linked to specific birth injuries or
Uh-huh.
complications rather than standard uncomplicated
Oh, okay. So it's everything is possible.
deliveries.
Okay. Yeah, I think what he's trying to say, everything is possible, but it's very uncommon. Yeah, that's why I was also skeptical. Even though anything can happen, but it's very rare. Yeah.
Mm.
Hello, Roger.
I asked because there's a woman on social media with a child
Uh-huh.
uh, with special needs, and I've seen two of them. They all have that. That is why I asked. And for the history they gave, it was like their birthing process was difficult. They had to go through assisted deliveries and all that.
Mm.
That's why I asked the question.
But Frank,
Oh, okay. Okay.
in U World Comprehensive Guide to, they said birth complications, particularly difficult deliveries involving instruments like forceps, can cause
Oh, okay. Okay.
strabismus
Okay. Okay.
by
Good.
injuring the nerves or intraocular muscles,
Good.
controlling eye alignment.
Oh, okay.
Yeah,
Okay.
that is the
Perfect. Thank you.
comprehensive that you gave to us.
Good. So it's even in our notes. Good.
Yeah.
Good. Thank you. Thank you. That's good.
Hello, Roger.
Yes.
Please, I have a
So it can
question.
happen. Thank you for sharing. Yeah. Mm-hmm.
Please, with the pictures you just showed, there was this picture
Yeah.
I was seeing that the man has all two eyes looking inward. So to me, I can't see any strong eye. So in conditions like this, how do you identify the strong eye for you to patch?
So they are all lazy. You treat one after the other.
Oh, okay.
Yeah.
Okay, thank you.
Yeah. So yeah, you treat one after the other. If they are all lazy, you can't leave them to do their own thing. You have to get them to work one after the other. Mhm. Any other question?
So, boss,
All
when
right.
I was also reading about it, I think I came across something like myasthenia gravis can also, I mean, cause it.
Good. So that is in adults, okay? Like a neurologic disorder, like those disorders. Yeah, they can cause that. Yeah,
Okay.
but we are looking at pedics, like pediatrics. Yeah. So for adults, stroke, head trauma, um, any issues like disease of the cranial nerves, the no cranial nerves innervate, especially those that innervate the movement of the eye. See, think we have trachea, oculomotor, right? Trachea, oculomotor. What other nerves? Um, like no, not trigeminal. Like we have muscles of the cranial nerves. Some of them which helps with the motor function or the motor movement of the eye. So when
What
they are
about
also
optic?
no optic is sensory. It has no
Oh,
motor
okay.
play. Yeah, so
Oh,
the optic nerve is,
All right.
is only for the sensory part. It helps you see. It doesn't move the eye. Yeah, so it's possible. Okay. My senior grade is possible. Any other question? I think we've learned something. Yeah, thank you all for sharing. All right. Let us carry on. So this is our next question. Uh-huh. So I read right here.
A nurse is assessing a toddler for possible hearing loss. Which of the following are clinical manifestations of a hearing impairment? Tata. 1. Uses telegraphic speech. 2. Speaks loudly. 3. Repeats sentences. 4. Appears shy. 5. Is overly attentive to their surroundings. I'll go
Okay.
for 1. I'll go for 2 and I'll go for 4.
Let us do it together. So, and please, you tell me why you are choosing your answer. So which ones? Do we choose one?
1.
Should we choose one?
Yes.
And why?
Um, when a child has to it is not always the case, but for some people that have hearing impairment, they need to look at your mouth to see the articulation of your mouth sometimes just to get what you are saying.
Do we all agree? Hey, where are the rest? Are we tired already?
Yes.
Okay. So we all agree, right?
Yes.
We all win together, we all fall together, right?
Yes, please.
Backing
Yes,
vocalist,
please.
yes. Okay, good. Let's carry on. What about option 2?
Yeah.
Yes.
And the reason?
Hmm. Let me try and explain. Please, I stand for correction. When children cannot hear well, it's like, for instance, you have a headphone on and you are listening to music. If you are speaking, because you cannot probably hear yourself so well, or you are let me use the word, accustomed to what you are hearing loudly in your ears, you tend to shout. So people who cannot hear so well, or they have hearing some level of hearing impairment, tend to shout because they cannot, in quotes, hear themselves so well when they are talking, and so
Okay.
they
Okay,
speak out
yeah.
of proportion.
Yeah, that is fine. Good. So we all agree, right? Or if you don't agree, just say yours. Otherwise,
No,
when
I don't
we
agree.
okay, good. You don't agree with the 2, right?
Yes.
So why don't you agree?
You see, you can't speak louder to someone who have hearing impairment.
Okay,
That's all.
okay.
Yeah. So you
So
don't
those
have
of
to
you
shout.
here,
It's not therapeutic.
okay,
Yeah.
okay. So those of you here, you learn something, okay? Just pay attention. So we have one who is refuting.
Um, Sergia,
Mhm.
please, I think our sister misunderstood the question
Uh-huh.
because she is saying like I think she thinks that we should like the nurse shouldn't speak loud or the nurse speaks loudly to the patient, but it's rather the other way around. The question says which of the following is a clinical manifestation. So what the child is doing, not you, the nurse doing. So the child rather speaks loudly. It's not the nurse who is speaking loudly. That makes it therapeutically wrong. So
Yes,
I
but
think my sister should read the question.
aside with this, my sister who just spoke, because the question is about the manifestation from the patient, not the nurse who is communicating to the patient.
Okay,
So
good,
it is about patient.
good,
So
good.
the patient speaks louder, but you, the one taking care, should rather speak in low tone.
It is very good. Most of you have been able to picture this. Yeah. So you see, one way that we normally miss out questions, it will not be like we don't know, okay? We actually know, but sometimes we just get lost in the heat of it, and that will make us choose wrong answers. I don't know if our sister understands it. Was this Abigail? Are you clear now? Or it
Yes,
wasn't
I'm
Abigail?
clear now. Yeah.
Are you sure?
Yes.
So in that manner. Okay. What about option 3?
It's not part.
Why?
This is typical. This is echolalia.
Okay, so it
And
means
it's
they heard
typical
something,
with children
right?
with,
And they are repeating
yes,
it,
they
right?
heard it and they are repeating. Good.
Okay. The next one.
Appear shy. I will go for it.
Okay. Do we all agree?
Yes.
Some people will not. Some people will not choose some. When the answer comes, then they'll be like, "Aha! I said it. I said it." You didn't say anything. If you have something to say it right now. Okay. All right. No one is refuting. Option 5. Is it part?
Please, can you explain the option 4?
Yes.
option 5 is part.
Yes. 5 is part.
Someone is asking about option 4. Who is asking about it? Hello.
I said the explanation to the option 4.
Is this a Jane who is asking?
No,
No,
Okay, it's a root. It's a root. You think option 4 is not part?
it's not that. I need the explanation.
But are you choosing it? We are all solving it together, so I want to know whether you are choosing it or not. Are you choosing it? Or you are leaving it blank?
No, I don't know whether I would choose it or what. But for me,
Option 5. I'm choosing it.
no, option
no,
4.
she's asking about option 4. Who can help explain it faster?
Okay.
okay. But yeah, except for children who do not have that cognitive power to determine what is happening around them. Every child who has some sort of disability or deformity, they know it, and it's sort of so they compare themselves with their peers, and it sort of makes them
It
shy.
dampens
They
them.
feel like, in quote, yes, they don't fit in. For children like that, except for those who don't have the cognitive power to know. But for those who know, that is how they feel. They feel shy.
Okay.
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 Sergio, please, I also want to ask a question. The question here says a toddler. At that age, can they
What's
really
the cutoff?
understand what's
What's the
going on?
cutoff age for toddlers? 1 to 3, right?
Yes,
Yeah.
please.
Yes,
One to
Can
three.
a
and they
3-year-old
know.
can a 3-year-old child be shy or not?
So
They can be
they can
over
be
shy.
shy, but as to, is it due to the possible hearing loss?
No, they don't know they have possible hearing. They may
Yeah,
not know.
that's why
Um,
that answer
So
is
are we
kept
choosing or not?
available. For me, I will not choose
Okay, so we have
because of the
okay.
toddler.
But yeah, I will
All right.
choose
but
it.
but
Okay, so some will choose,
but
some will not
yeah,
choose. That's fine. We will look at it. Okay.
okay.
Uh-huh. Option 5.
But yeah, my confidence level is not high on option 5, but I
Yes,
want to go
please.
for
Option
it.
5.
Is someone choosing?
Yes, please.
Okay, and someone says confidence level is not there. So for wow, for 3 options, we have different answers coming in. Wow. What if I tell you no matter so please, aside the 2, 4, and 5
So please,
that
I
we
have
have
issue with
different.
the 3. With the
You
3,
also have,
is it that the child who is repeating the sentence or asking others to repeat it?
the clinical manifestations. Where are we? Where are we tracing it from? Let us understand from this point. Then you will see.
Everything
Where
is
do we
centered.
want?
Everything is centered
Where,
from the child. I want to see.
yes. So when we say repeat sentences, it means we are looking it from the child.
The
Do the
child
child repeat
repeating it.
sentences? Do you
Okay.
get it?
Okay, yeah.
Uh-huh. So that's how you link it. So apart from 2, 4, and 5. Are we all on the same page on option 3 that it is wrong and option 1 that it is correct? Are you on the same page on this ones? Hey, still, Vim is not there. So we are all wrong. Okay, we fall down well, but you're all wrong. Choosing option 1 as correct makes the whole thing wrong. And in our Q bank, we will mark you wrong for everything. On the main enclave and on the Q bank, you get a partial score, but our pretest, you'll be marked all wrong. Okay, for partial mark. So let me tell you something. When we say uses telegraphic speech, do you understand telegraphic speech?
Yeah, I understand.
Yeah.
Let me give you an example of telegraphic speech. Okay, let's say daddy is going to work. Okay, and you be like daddy go work. Okay, it's like shortcut, using shortcut form like a slang something. Okay, um let's say I want juice, then you be like want juice. You see that thing? So it's like you instead of
That can help.
saying one whole sentence, you tend to pick out a shortcut to it or something, right?
Yeah,
Like
don't say
maybe, are you talking to us? Who is this? Jacob.
Oh, sorry, sorry.
Jacob. Yeah. So like the dog is sleeping, you be like dog sleeping. That is what we call telegraphic. That's what we call telegraphic speech. Okay. So um, uh, telegraphic speech. Okay, that's what we call it. And if someone can hear something enough, be able to even make shortcuts, doesn't mean the person has hearing loss. So that makes one not part of it. Okay. So the answers are only two. That is 2 and 4. Only this one. And of course, those of you who were skeptical about this, they feel shy. People with hearing loss, whether they are kids, I mean, especially it starts from toddlers, okay? Whether they are toddlers or adults, you feel some kind of shyness, okay? And because they don't hear themselves talk, when they speak loudly. Okay, just imagine when you have a headset, when you are wearing a headset and you're even talking to your next, I mean, a person closer to you. Do you talk normally? Your voice your voice tends to be a bit higher. You're thinking if you don't raise up your voice, the person closer to you will not hear you. So that is how it is, just like that. Any question on this one? It's tricky, right? You've been getting select order to apply questions in life class. This one you had it wrong. Okay, so that's the quick
Bonji,
question.
I have a question.
Yes, ask it.
Um, is it possible that you have a child with um some level of hearing impairment, and the child will look at you at your mouth to get what you are saying? Does it
Yeah,
happen?
yeah, of course. It's there.
And please, what is that one called?
Yeah, it's not
Um, w-
telegraphic though.
well,
Yeah.
maybe
Because that's
maybe
what I
someone can
thought
help
was
us
a
with the.
telegraphic.
No, that is
Is
not
there a name?
telegraphic. Mhm.
Entire explanation of my mind was towards that. So, is there a name for it, or they will
So
just describe it?
so you were explaining something else that you didn't even know. Okay. So I think mostly they use mumbling, right? Something like mumbling. Okay, they try to mumble as you speak or imitate what you speak. I don't know. Our grammarians are here if there's a single word to represent that, I can tell. But What I know is mumbling. Okay. All right. This is our next question.
A client who has admitted eh,
A client who has
okay, a client
admitted
who
to
has
heavy.
admitted to heavy alcohol use throughout her pregnancy just delivered a 6 pound baby.
So if you
Which
want to know the
signs and
equivalent
symptoms?
of the pound, you change to kilogram by doing what?
Dividing by 2.2.
Okay. Let's carry on.
Which signs and symptoms in the mother should the nurse anticipate in the 12 to 24-hour postpartum period? Select all that applies. A. Neonatal abstinence syndrome. B. Fetal alcohol syndrome. C. Seizures. D. Delirium tremens.
Delirium tremens, right? Is it tremens or tremors?
A. Tremens. Sorry.
My grammarians are here. When I even get it wrong, they correct me. So be careful.
Yes,
Uh-huh.
boss.
So select all that apply. Which
The
ones are we
answer
choosing? Let's
is
do it together. Is
C.
A part?
C and G.
No.
C and D.
No.
Oh, B and D. Wow.
Yes.
C and D.
C and D.
Yes.
Oh,
Think
I even forgot. We did this question last week. You
Yes.
remember? Oh,
that
so some
question.
people are memorizing the answers. They will not even look at, or we actually know.
We
Do we
know
actually know?
because the
The
first
We
next
two is
know.
question.
talking about the child, the baby.
Okay.
Then
Okay.
the last two is talking about the
Yeah.
mom, and this question is about the mom.
Yeah. Yeah. So it's C and D. We did this.
Mm.
I mean, this was the last question we did before we ended last week. Yeah, that's true. All right. The next question.
In planning care for the fetal alcohol syndrome newborn, which intervention would the nurse include? One, allow extra time for feedings. Two, assign different personnel to the newborn every day. Three, place the newborn in a well-lit room. Four, monitor for hyperthermia.
Yes, what's the answer? We did
Hmm.
fetal alcohol syndrome not long ago. So what's the answer? I knew if I had brought
One.
the options, or like if I had brought the questions right after that, you would have, because the information
It's
uh,
fresh.
would be fresh, you'll be able to get. So I accumulated it and brought it to the side. Someone said one. Why one?
For children like that or newborns like that, you know that um should I say they are drowsy most of the time. So if you
Are they
just
drowsy?
Very
not
well.
drowsy, not drowsy, yeah, for lack of better word.
Okay. Okay. But do we all agree it's one? Let me do something. Abdul Razak Madia, right?
Please, yes. Oh.
Do you agree it's one?
It's 50-50. Oh.
Hmm.
I'm still thinking.
50-50.
Hmm, I'm still thinking.
Okay. Okay. Ifya Brago. Ifya Brago. What do you think? Ifya, your name is here. So let us hear from you. Right. We know you are here. You are listening to us. Uh-huh. Brago.
Hello, Bonjour.
Uh-huh. I know you are there. Uh-huh.
Um, so I'll also choose one because I think the
Uh-huh.
other options are wrong. I'm not sure, but
Oh,
For
you
me,
think you
yes.
just
If
think
I
you are
was
wrong.
doing it
Magical,
personally.
magical thinking. All right.
Mhm.
So yes, the correct answer is one. Okay. Yeah. So generally when you get questions on fetal alcohol syndrome, most of the time they link it to their feeding. Okay. So even if we learned a lot about the fetal alcohol syndrome before, how their their facial like I mean how should I even I'm also looking for this word, how
Features.
their facial nature is, yeah, or arrangement,
Features.
those
Yeah.
features here, good. They are how their facial features are. Okay, some are very common to which condition? Down syndrome, Some of them are especially the flat face and yeah. And yeah, so I mean generally when you get questions on fetal alcohol syndrome, watch out for feeding. I mean answers that link to feeding. Watch out for it, very, very careful. I'm not saying that you should throw away all possible answers. Just consider the rest too and see which one fits better. But always, if there's issue with feeding, look at it well. For more than 60-70% of the chance, they link it to what? Feeding issues. Okay. So that is one trick. Okay. So you give them more time because they have feeding problems. So you give them more time and you have to be patient with them when they feed. Okay. All right. The next question.
What does the nursing care for infants with fetal alcohol syndrome include?
This one, let us
A.
all say, what I just explained. What do you think the answer will
It's
be?
A. This one there is
A,
A.
nutritional
Uh-huh.
guidance.
You
A.
see?
Nutritional guidance.
Uh-huh. Uh-huh. So that is how I want us to answer the rest. Okay. So you see, that's how the questions are. When mostly you see fetal alcohol syndrome and you look at the options and it's directly or among one option you have nutrition or feeding issues. Just look at that well. It's likely to be the answer. Okay, so that's true. Yes, our next question on Down syndrome. Let's go.
The genetic testing of a child with Down syndrome showed that the disorder was caused by chromosomal translocation. The parents asked about further genetic testing. Based on the nurse's knowledge on genetics, the most appropriate recommendation is A. No further genetic testing of the family is indicated. B. The child should be retested to confirm the diagnosis of Down syndrome. C. The mother should be tested if she is over age 35. And D. The parents can be tested since it might be hereditary.
Mm-hmm.
Was yeah.
Mm-hmm.
C. C.
Um,
Okay, boss, I also think of the sense we are talking about hereditary.
you choose D, right? D for dog.
Yes, because we are talking of hereditary. If the child has Down syndrome, it is linked to hereditary, then we might need to test the parents to see whether it is actually
Good,
transferred from the child.
good. I like how you think. I like how you think for this
Was
question.
yeah.
Yeah. So that is it. That's the answer. Yeah.
Sir,
Someone told me. Hmm?
sir,
Was yeah.
Yes.
I want to
please,
understand
can you
something.
further
Okay.
explain it? I don't understand the question.
You, Brother Jacob, they said they don't understand. No. Make them understand, okay, how you understood yours.
Okay, this is the little understanding I got from the question. The preamble says that the genetic testing of a child shows that shows Down syndrome. So and then we are also made to understand that it is caused by chromosomal translocation or something that's linked to the genetics. It means that you can't get it from any other thing apart from it being transferred from your parents to you. So if you have got a sickness that is genetic and you want to confirm, you may need to see whether to test the parent to see whether which of them has transferred the defective gene to the child. So if you test and see that the parent have it, then you are rest assured that because the parents have it, you are not surprised that the child also have it because it is hereditary disease. It can be transferred from the parents to the child. So that's why I went for the option D.
Okay. Do we all get it now?
Okay, thank you. Okay, thank you.
All right. So Jacob, you'll be my TA, okay? Yes, sister. Let us hear from you.
Please, I have a question.
Ask your
Down
question.
syndrome is trisomy 21, right?
Mm-hmm.
I want to clarify to correct what I have in my mind. What I got
Okay.
was that what I thought was that around the time where there is you see, so there are supposed to be 23 pairs, and there is an extra pair, which probably was out of um
On the 21st one, okay, that is why it's
yes,
also called trisomy 21. Okay, yeah.
yes,
Let's go.
on the 21st one. So I
Hmm?
thought it was rather the linking process while the child is being formed in the womb that causes the problem. It means that so that's what I thought. So under normal circumstance, any person on any day could get Down syndrome. So this is telling me that if a child gets Down syndrome, then it means that the mother or the father is a carrier of Down syndrome trait, right?
Yes, that's what we are saying.
Okay, thank you very much.
Do you understand it now? That is why
Yeah,
it points more to D than the rest.
yes, I understand now. It has really clarified something for me today because my thought was wrong all along.
Oh, okay. Okay. All right.
Thank you.
You are welcome. Warmly welcome. All right.
Bonjour,
Hello,
please. I
bonjour.
have a question.
We can look at, let us read this rationale, then maybe to add up maybe one or two things. Then from here, if you have any question, you can ask. Okay.
Yes, please. Bonjour, I have a question.
Please ask. My TA is here to
Okay.
help me, okay? Jacob is here to help you. Let's go.
Okay. Bonjour, please. I was wondering if if someone has a Down syndrome, there are physical features you can see. So
Once again,
if any of the parents have the Down syndrome, wouldn't it be obvious? Do we need the testing to confirm? I'm just curious.
Okay, good evening.
he
Me,
said
I'm not
if,
the man, but around.
hey, is it the same person asking the question?
No, I'm not the one.
It's someone else? Hey. Okay, so your question is, okay, Sadarity, you want to answer. Sadarity want to answer you. Sadarity, let's go. Sadarity, your hand is up. Is it a mistake? Okay, maybe it's a mistake. He's not talking. All right. So, Jacob,
Boss,
yeah, I'm here. Let's go.
like I don't get her question. You should repeat herself, please.
Okay.
Okay, I was asking based on the answer to this question, they said the parents should be tested. So, and I'm curious if any of the parents had the Down syndrome gene, wouldn't there be some physical features to tell to even suggest? Do we really need to do the testing? If you see someone who has Down syndrome, there are features you will see, but someone who doesn't have will not have those physical features. So I want to understand if you look at someone and the person is not exhibiting any of those physical features of Down syndrome, do you need to really test that person? That's what I want to understand.
Okay, my little understanding of genetics is that if somebody is a carrier, not every genetic link disease that you need only one gene to show. When I say one gene to show, we said by the constitution, chromosomal constitution, we have 23 pairs. That means 23 from the mother, 23 from the father. So if the father is carrier and it is recessive, the disease is a recessive autosomal, it means that you need two defective genes to be able to exhibit characteristics of that particular condition. But if it is a, what do you call it? There are other ones to, yes, dominant. If the dominant, you need one to show. Okay. So now the question in the question, they are talking about it, which means that it could be that the mother is a recessive, that means carrying only one, a carrier, and the father too could be a recessive. So if you do the genetic crossing, there's a possibility that if two carriers meet, then they will get 50% of their children being defective and 50 being what? Being normal. So in this case, it's likely to be that both of them are carriers. That is why they themselves are not showing, because they are having recessive. If this one have recessive, this one have recessive, if they are not dominant, then they will not show because they are just carriers. But if the two are carriers meet and they produce, 50% of the children will carry the defective gene, and the 50 will be correct. So possibly this child is among the 50 that are affected. That's my simple.
Oh, sorry, Jacob. Jacob, unmute yourself. I mistakenly muted you. Someone was making noise. Sorry.
Okay, what I'm saying is that when it comes to conditions that are transferred through genes, we have the autosomal, and then we have the dominant and the recessive. When you are having the recessive defective gene, it means that you need two recessive genes to show the characteristic of a particular condition. So let's assume that you are a carrier of a particular genetic disorder, and that disorder is a recessive disorder. It means that you need two defective genes in the child for the child to show. So you, the parent, will not show because you are just a carrier, and that particular disease is a recessive one. It's not a dominant one. So if two parents, all of them are carriers, and then the defective gene is a recessive, it means that they need to contribute one defective recessive gene each to the child in order for the child to show a full characteristic or to exhibit that particular condition.
An example is,
So,
I think an actual example is sickle cell disease, right?
yes. So
Yes, that's what I wanted to say.
Yes.
In this case, it's likely that the father is a carrier with a recessive gene, and the mother too is a carrier with a recessive gene. So when the two carriers come together, 50% of the children will be defective and 50% will be correct. So it means that this child happened to be among the 50 who are affected by this condition. That's why the child should show the symptom, but the parents will not show because they are simply carriers, and it is what? Recessive. Thank you.
Sister, do you understand it now?
Yes, and again too, I think the rationale to have also added to my understanding
Okay.
with what you
Okay.
said. So thank you so much.
Okay. All right. All right. Hey, we still have more hands. Okay, Jane, you keep on talking. Wait, let me take you've been talking a lot. Let me take Hussein. Hussein has not been talking. Then after you can come in, okay?
Okay, boss, thank you so much. Oh. My own is not like I wanted to add something. In fact, unfortunately, the network took me out. The network took me out. So I couldn't see the question. I just wanted to take a look at the question or snap it so that I'll compare with the explanation.
You are part of those who have been snapping, right?
Network, network. Oh,
You Akwaba. Okay.
more network.
Sorry. Did you get it? I think he's still slowing on network.
No, please. Actually, I missed it. Then my network took me out, boss. But I'm sorry,
So,
Brian.
so like I've opened it for
Yeah,
I mean, that
yeah.
is on the screen right now, and I'm asking,
Wow.
do you have it now?
Thank you, thank you, thank you,
Okay.
thank you so much. I'm good.
Jane? All right. Jane,
Yes, boss.
are you
So
okay?
Yeah, I've
Good.
gotten it, boss. Thank you so much.
Oh, all right. Hussein, I think your network is still delaying.
Definitely.
Anyway, we've heard you, okay? Jane, let's go.
so um I try to understand the Down syndrome thing. So it means that the translocation Down syndrome is the only one
Yes, boss.
that
I've
is,
gotten it. No,
let me say, hereditary, right?
Carry on. Jane.
So the translocation Down syndrome type is the one that is hereditary, that is carried by either one or one of the parents. But
Yeah,
the
yeah,
rest is caused by this disjointed coordination of the chromosomes when the baby is forming.
yeah.
Please, am I right? Okay.
Okay. I think one day we should do genetics, right? You have to do some serious genetics here. We have many genetic engineers here in the future. Yeah, let's carry on.
You are taking care of a middle-aged child who has a hearing deficit in the hospital setting and uses lip reading as part of her communication pattern.
You've seen
Which
your word,
factor?
right?
Yes, please.
Okay. Huh?
Which factor would help to enhance this interaction? A. Make sure that one of her parents and or family members is in the room with her at all times to facilitate communication. B. Stand approximately 50 feet away from the child so that she can best visualize your face. C. Keep sentence structure short. And D. Speak at fast pace rate.
Mm-hmm. Yes.
The answer is A.
The answer is A.
Okay. Why A?
In fact,
You see
this
this?
question was solved by us this afternoon during the question and answer session. It's similar. It's not the same, but
Wow.
similar.
Wow.
It's
So
similar, not the
you see, this time, the pool of questions that I normally bring that you easily spot, I changed my way, and I see that this one is now drawing some tension, right? Even those choosing A, you are like, is it actually A, right? You are asking second question in your mind, and those of you who are like, well, let me be here, let them choose and let me see. I hope you are there. Backstages, are you there? All
Yes,
right. We all win together. We all lose together, right?
we did.
We did, yeah. Okay. Are we all choosing A? I mean,
I'm
those who are
choosing
trying.
C. I'm choosing C.
Please,
Aha.
I'm choosing C.
Yes,
I'm choosing
I'm
C.
interested in the
Hey,
different answer. Our sister who said C. Why C? I'm interested.
Yeah, I'm choosing C because they said the child uses lip reading to
Mm-hmm.
understand what you are saying.
Mm-hmm.
So when you make your sentence short, as the child read your lips, the child will better understand. But bringing a parent, that doesn't help. They said the child uses lip reading. I
You
would have
see?
gone for B, but I don't know if the 50 feet is too far
Mm-hmm.
because they said the child can visualize your face. That one is good. But the
yes,
50 feet, I think, is too far.
I think of B, but that 50 feet, I'm not so sure too.
Mm-hmm. Mm-hmm. The B people, the B people explained. Oh, all my B people are lost, and all my A people. So the answer is C. Okay. Are we all on the same page? I want us to finish with the questions before we go. Okay, so spare me some time, please. Can we carry on? All right, the next one.
A nurse working in a pediatric clinic recognizes that which child is most at risk for cognitive impairment. A. An infant who is being fed reconstituted formula, powdered formula. B. A toddler living in an old home that is being remolded. C. A preschooler who attends a playground 3 days a week. And D. A school-age child who rides a, a school bus 5 days a week.
B.
Hmm?
B.
B.
This one is
B.
quite
Blood
easy, right?
poison.
Yeah, this one there. This one everybody should
Third
do.
poison.
All right. Anyone with any issue with this one? I don't think so, right? The next one.
The major consideration when selecting toys for a child who is cognitively impaired is A. Safety. B. Ability to provide exercise. C. Age appropriate. D. Ability to teach useful skills. A.
Safety.
A,
Safe.
safety.
So whenever you are going to the NCLEX, have it in mind that the NCLEX is what?
Clarity is
A
safety
safety
exam.
what? Exam. Anything about safety. Okay? All right. So that is the correct answer. The next one.
When caring for a newborn with Down syndrome, the nurse should be aware that the most common congenital anomaly associated with Down syndrome is A.
This one is easy.
Hypospadias.
Which one?
A. A. Hypospadias. C. Congenital heart disease. B. Pyloric stenosis. D. Congenital lip
Oh, I
dysplasia.
messed it up. I did it ACBD. It is ABCD. Okay, sorry. So which one is the answer? Oh, this should be easy.
C.
I'll go for C.
B.
C,
Congenital
C,
heart.
C.
Okay. So
Congenital
so
heart disease.
my B and C's are messed up. Just mention the word. So what's the answer?
Congenital heart
Congenital
disease.
heart disease.
Yes, congenital heart disease.
Congenital
Okay.
disease.
Okay. I want to do something. Um, I want three people who I want to give one assignment. I mean, some kind of assignment. Any three people who can volunteer for me? Three volunteers. Raise up your hand if you wish. You can raise up your hand here so that I can see you. Okay, I have first one. Sister Rita, good. Keep the hand up. Sister Sarah, keep the hand up. Last one. Sister Jane. Okay. Good. Yes, Arita,
Yes, boss.
prepare a nice. Oh, okay, I have more hands. Good. Yes, Arita, prepare a nice slide on hypospadias for
All
presentation
right,
for us.
sir.
Okay.
All right.
All right. Good. Mr. Jane,
Yeah.
congenital heart disease, we've done it here, so we shouldn't spend time on this one again. Do pyloric stenosis. Okay.
Okay.
Jacob, yeah, Jacob, do congenital hip dysplasia. Please, the rest of you, we still have some topics around. I'm going to structure it so that we don't use much time. You can send me a message after class, right? If you are interested, so that we do that, right? And I'll send you a topic personally. Okay. All right. Thank you. Thank you for your cooperation. All right. Then I think we have the next question here. Still pardon me. I don't want us to keep long with the pediatrics. So I want us to just find a way to cut a lot of things short and cover as much as we can. Okay. Yeah. So the next question, kindly take it for us. We have about three more questions after this, then we can go. Okay. So that tomorrow we start with a new topic. Let's again. Let's go.
And then a nurse is providing a parent information regarding autism. Which statement made by the parent indicates understanding of the teaching? A. Autism is characterized by periods of remission and exacerbation. B. The onset of autism usually occurs before 3 years of age. C. Children with autism have imitation and gesturing skills. And D. Autism can be treated effectively with medicine.
What's the answer?
B.
A. B. B.
Are we all choosing B? I think this one when we were explaining autism, I mentioned it, right? Do you remember?
Yes, please. B.
Yeah, those of you who still remember. The answer is B. Any question on this one? We are just trying to. Okay, Sarita, you have a question? Or it's an old hand. So you
Yes,
are
it's
just
an
trying to
old
recap.
idea.
Okay, all right. Our next question.
A parent asks how to prevent positional pleg- plagiocra- plagioccephaly,
Plagiocephaly, yeah. Or someone will say
which,
plagiocephaly. Depends on
which
the kind of international school.
plagiocephaly, which
Some will
nursing
say cephalic.
instruction is most appropriate? A. Place the infant on the stomach during sleep. B. Keep the infant in a car seat whenever possible. C. Encourage supervised tummy time while awake. And D. Use a pillow under the infant's head. C.
C.
So we did
D.
this not long ago. What's
Mm.
the answer?
D.
Far away.
Which one?
C.
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 D for cat. Yes, that's correct. So you have to encourage supervised stomach time while awake. Yes, that is correct. And next question.
Which infant is at greatest risk for developing positional plagiocephaly? A. An infant who receives daily tummy time. B. An infant who spends long periods in a car seat. C. An infant who rolls independently. And D. An infant who sleeps in a crib without pillows.
Oh, long time. If I
An
Is
infant
it
B.
tricky?
B.
not getting
B.
Someone is saying B. Do we all rise together and do we all fall together? Or you have different choice? If you have different choice, let us hear from you. Okay, those of us who don't have any choice, let us raise up our hand.
no,
And
no,
people have no choice.
thank you.
Sister Dorothy, what's your
Hmm?
answer? Or you have no choice? I want about three trials, like three people to try. You can unmute and talk to us. Hey, so you have this question on the English. Choose the correct answer and pass, or choose the wrong answer and fail. What will be your last shot?
But I'll choose D.
E.
B, B for boy or D for dog?
B for
B for
boy.
boy.
Yes. So in this case, we all pass the English, right?
Yeah.
Yeah. So that's good. That's good. Anyone who doesn't understand this one, the person can let us know so we can help you more here. All right. The next question.
A nurse evaluates teachings about positional plesiocephaly. Which parent statement requires further teaching? A. I will limit time in swings and careers. B. I will hold my baby more often. C. I will use a pillow to prevent head flattening. And D. I will encourage tummy time.
Mm-hmm.
C.
I'll use to prevent head flat.
Someone says C.
D.
Do we all agree to C?
Yes.
Yes, the answer is C. Okay. The answer is C. So the sudden infant death we talked about, see? Yeah. So God willing, tomorrow, Marfan syndrome. Marfan syndrome is an autosomal dominant connective tissue disorder caused by mutations in the FBN1 gene, that's the full gene. Please, for case purposes, forget about the gene, okay? Just know that it's caused by mutations in like genetic mutation. Okay, simple as that. And it primarily affects. So take note of where it affects. Okay, so take note of these things. Okay, it affects cardiovascular system, your musculoskeletal system, and ocular system. Okay, the connective tissue disorder. And these are some of the signs and symptoms you see with cardiovascular, which is the highest priority. So when it comes to, generally, when someone is not doing well and the person has to be resuscitated or in high class emergencies, you go with CAB, that is circulation, airway, and breathing, right? So anything cardiovascular, you have to take prompt action. Okay, so anything cardiovascular is the priority. So some of the things you have to see, or you will see in patients with Marfan syndrome are aortic root dilation, aortic aneurysm. You know your aorta, right? I'll show you pictures very soon. Don't worry. Then you can have aortic dissection. This alone is also a major topic in NCLEX, right? That is where you have your aorta, section of your aorta that being dissected or opening up. You don't have time when you get it. This is life threatening. Your aorta is one major vessel in your heart, right? It's it is it is connected directly to your left ventricle, and it is through your aorta that you have other branches of your arteries sending blood to various parts of the body. So you can just imagine the pressure, kind of pressure within this vessel, right? You can have mitral valve prolapse, heart murmur. Okay. So this is just a side question. Let me ask you, generally, in when someone has aortic dissection, let's say a risk factor or aortic aneurysm, what is the priority when it comes to monitoring the patient? I don't know. This is a general question. I don't know whether someone remembers something about it. It's a high yield English question. I don't know. I don't want to give options, otherwise someone will catch it.
Is
When
it the
it comes to
blood
management
pressure?
of blood pressure, good. Okay, you always want to keep the blood pressure of the person at an optimum rate, okay, or at a very normal level. Because when it goes high, you can have the aneurysm being ruptured. Okay? You can have aneurysm rupture. It's a very serious thing. So any aneurysm anywhere, it's no friend for what high blood pressure, because it can cause the aneurysm to burst. So just take note. All right. So these are some of the things you find. Okay. For cardiovascular. Now let us see. So for ocular, these are some of the things that you see. You see lens discoloration, dislocation. Another name for it is ectopia lentis. Okay, ectopia lentis. That's lens dislocation. I'll show you. You can see myopia, that is nearsightedness. You can have increased risk of retinal detachment. Okay, all right. And yeah, these are some of the things you see. Okay, these are the some of the signs. So this is the okay. So let me start from the left hand side with the assessment findings. We said the first one here, we are saying arm span greater than height. We look at here, arm span. That is like, generally for every normal human being, your arm span, when we say arm span, it's like when you raise up your hand, laterally. Okay, happen. You see, like when you put up your head up like laterally, like this, your height should almost be equal to this length, almost. Okay, your entire height should be almost equal to this one. We have some people too. You can have arm span which is slightly greater than your height. That is also normal. But with these people, it's more like it's more lengthy. Okay, like the height. I mean the arm span is too wide. Okay, for people with Marfan syndrome. So when you see things like arm span greater than or which exceed the patient height, even though most of them can be normal or even normal people, but with Marfan syndrome, it exceeds. Let me use the word for proper understanding. It over exceeds. So that's the meaning of that word. Okay. Let me back. Let's see. The second one is what positive wrist and thumb sign. Okay. Positive wrist and thumb sign. Can you see how it is? Who can see? Who notice the differences? Who notice the differences?
Please, I didn't get the question.
We are trying to I'm trying to show you the pictures of what we have here under the assessment findings. Okay, over here. So I'm just trying to ask you what is the positive risk and term sign is the second picture you see here. So like who noticed the differences?
So ideally, if you should fold your fingers over your thumb that way, your thumb shouldn't appear
Come
at
out
the
like that.
end of the small finger.
Mm-hmm.
Yeah. But in this people, it's like their thumb looks a little longer. So when you fold it, You fold your four fingers over the thumb. It's still showing at the end.
Good. That's so that goes for what is it? Sorry. Oh. So that goes for the positive thumb sign. Okay. Thanks for that explanation. It's a very nice explanation to it. So that goes for the thumb sign. And the wrist sign, so there's a thumb sign. So you see when you put your because every part of their body is like abnormally elongated. Okay. You see, how many people can do this? If you can do it, means you have a fan syndrome. This is just what I do. So when you fold your thumb inside and you wrap your four fingers like our brother said, and as you see here, okay, you see the number of, the length of the rest of the time you can still see. That's positive thumb sign. And this is the positive wrist sign. Okay. Actually, I know many people can wrap their well, is it many people? Or we have variations in anatomy though, but with Marfan syndrome, you see their little finger, okay, when you wrap it around with your thumb, okay, on the wrist, the best you should do is maybe to touch it a little, right? The best you should do, but these people they can actually place their thumb on the little finger, like they can wrap all around. So that is also one sign to also, um, I mean, show, okay, with the assessment findings. So that's what you see here. And with the I one, look at how it is here. We are saying lens, sorry, is that one? No, I think that one is the lens dislocation. Yeah, that's the lens dislocation here. Okay, yeah, dislocation or ectopia lenses. So that's how you see the eyes. Okay, that's how you see the eyes. Lens dislocation. All right, and because it's a connective tissue disorder, they will have this abnormal curvature and all of that. It's a connective. A bone. The bones are also connective tissues. Okay, so you have deformities in all of them. Okay, and the right side over here, like in picture B here on this side. I hope you can all see this picture or this X-ray is also showing like some abnormal heart enlargement and cardiac abnormalities, right? So these are some of the things you will see with regards to Marfan syndrome. And okay, let me get there also. Lesson management. How do you manage this patient? Let me see if I can give you additional tips here. How do you see they are very elongated. See how they look like. See this one. I think you would also shows a nice picture of it, and it's strange a bit. So they have eye problems, abnormal heart problems. Okay, so another thing, so they have short torso. Okay. They have thin and thin, they are tall and thin body frame. Okay, so all these are part of it. They have long arms, long legs, every part is long. So these are bodies not. All right, you can see them. and all those things. So you see, they can only have these policies and these things, right? Yeah. So they are all part of Marfan syndrome. So nursing management, how do we manage these patients? Monitor cardiovascular status closely. Remember, we said their priority, the priority management is with the cardiovascular aspects, okay? And regular echocardiograms to assess the iota is very important. Administer prescribed beta blockers or ARBs, that's angiotensin receptor blockers, to reduce aortic stress, okay? So things to bring down the blood pressure so that, like we said, high blood pressures are not friend. They're not friend. Okay, it's not friendly to. They're not friendly to aortic issues. That's what I want to say. Encourage low impact activities. These low impact activities, they can ask you questions like contact sports. They are sports that they can perform. Okay, but any sport they mention that involves body contact, they cannot. Otherwise, you can have fractures, right? So take note. All right. So I think it's here. Avoid contact sports and heavyweight lifting. Yeah. And low impact activities too. So they are 20 points here. Complications. Aortic dissection. That is the most serious complication that can happen if someone has Marfan syndrome. Heart failure can happen and retinal detachment. People are born with it. It's not their fault, right? These are some of the things you can see and how to manage them. And you've seen the pictures too, right? So let's look at some takeaway home for this condition. I hope you don't forget about it. We've summarized it enough, and things that matters to the English on Marfan syndrome is what is being shared. How you know they have Marfan syndrome is normally based on physical assessment. Okay, that is how we've gone through. So the healthcare provider will assess all these things and can know that yes, it's actually what Marfan syndrome. It's enough. Okay, with heart complications coming in to add up to the physical assessment. This alone can be used to diagnose. So priority concern is the aortic rupture or dissection. So sudden chest when patient complains. So if you have whether a case study question or something and the question is like patient suddenly complains of chest pain, even whether with Marfan syndrome or not, it's emergency. So you can spot that. I hope everybody can spot that already. So sudden chest pain or even back pain, okay, or abdominal pain. Even in MI, myocardial infarction with um people of older ages, especially among women, they don't even complain of chest pain when it comes to MI. They normally complain of abdominal pain. Don't think of any organ abdomen. It would be MI, which is actually happening in that is in MI. This is just side just to say. So this one too can have and the aorta when it's leaves the heart, you can picture the I wanted to show you this aortic dissection. Um okay, so okay. So you see, this is the aorta. So it's coming from the left ventricle, right? Before it branches to the three main divisions where you have two of them doing one main. You have some going to the brain, some going to the main. So, this one elevates the upper part of the body. So I said it supplies that to the upper part of the body. And you have so this is the abdominal. So here is the abdominal aorta. So this is coming from the heart Then you have the three main divisions. I've forgotten their names. Um, two, two branches. Well, the anatomy I've forgotten, but some will go to the left and right, um, like legs. Okay, that's your four legs. Then some will also go to to your head. Okay, on your lateral side of your neck. Then it will supply your brain and all the other regions. So this is the abdominal aorta. This one comes down, supply, I mean the lower part of the body. So you can just imagine this is also pulsating, and the pressure in the left ventricles is also transferred, and it's in here. So it is the pressure in here that comes down, and at the end of the day, you feel some at your femoral artery. You know how sometimes how heavier it beats and your pedal forces. So all those pressures are coming from here. So the pressure within this is very, very, very high already. Okay. So when the blood pressures are too high, so you see, there's an enlarged aorta already. Okay, so when the blood pressure becomes too much and rupture, and when this one ruptures, well, even in advanced worlds, if you don't take time, I mean, you will not even have time to eat, okay, because it's very dangerous and it requires rapid attention. Okay, so the next we want to talk about, we're saying the affect the eyesight, we talk about eyes, look at the lens, and you have long bone. So, so Mapan, yes, about it. Mapan means you have long with your limbs, so only the abdomen, which is short. Every part of your body is long. So Mapan, I know someone has a nickname here called Long Man. Who is called Long Man here? Okay, someone's nickname anyway. So Mapan means long. Okay, and yeah. Any question on this one? Any question on Mapan syndrome?
Yes, please.
Okay, you can
I,
ask
I
before we.
I understand what you've done so far, but in the case where there is the aortic dissection, what is done for the patient?
It's surgery. Okay. So aortic dissection is aortic dissection is something big, and please, it's time bound surgery. Let me just um so it depends, but please, it's surgery. Okay, it's surgery. I'm trying to think about it.
And do they have a good chance of survival with surgeries?
It depends on how fast the person it's how fast the person seek prompt intervention. Okay, it's how fast, because and it also depends on the size of the aneurysm. Aneurysms have size, and I've met a patient. I think I've met before. No, normally to start with, they have complaint of very like lower back pain, chest pain, and all of that. Sometimes abdominal pain. That is very unbearable. No painkillers can sometimes. They'll take this CT scan, the scan will measure the size. They'll be giving medications to take to help. Depend on the size. If the size is very small, it will not require surgery, just contemporary management. But when the size, I can't tell which size that will require surgery. But when the size is bigger, that one, I know, it's like lot of surgeries, And let me use polycystic ovarian syndrome as an example. When you have those cysts in there, there are some medications that can clear them, depending on the size of the cyst. But when the cyst is very large, it requires surgery to get better, so that they can remove the cyst. So it's like this one too. If the aneurysm is small, you can give medication just to control, so that because the surgery itself is life threatening. Like like I don't know whether it's the right thing, but it's very invasive. Yeah, that's what I want to say. Very invasive. So cardiovascular surgeons the will weigh the risk of the surgery and actual side of it. If it's something that you can manage, give it time. If you can live long with it, fine. But if it worsens, if the size becomes big, it requires surgery. But what we don't want is, when it fractures something, okay? When it fractures something. So this is, you have layers of the blood vessel. This is also a very big blood vessel. You have layers. So people remember the layers. You have I think the inside one is the intima, right? We have intima, what's the middle layer? What's not the middle layer? We have intima. Okay, fine. For the purpose of people of most of us here have forgotten anatomy like you. Okay, so the inside one I know is intima. So when the intima ruptures, the blood moves from the inside to other layers, making the outer part bond. Okay, so the higher the pressure, then it will be tearing, it will be getting bigger. But when it ruptures, well, I don't know if how many minutes you have. So look at this one. I think this is a surgery that has been done to repair. Yeah, this is a surgery. You see mesh around it or something. Yeah. See, that's surgery. So surgery is the only thing that can correct it. But how much time you have, what is important. If we are now coming to raise millions of money on social media for you, that, that's that's one thing about where we come from. And in advanced world, when you have things like this, whether you have money or you don't, most of the time, unless I think there are specific ones that are made very different, but general health care, they give it to you whether you are. So I've encountered some before. Someone found someone unconscious. I think the person was homeless, very dirty. In our place, I will say madman, right? Person was got very needed an ICU care. We didn't even know the patient needed everything because no one. So we're using a code for the patient. I mean, to identify the senior. And we gave him care. I mean, like we give the person, everything was 100%. Like we gave care as we would give to anybody. That's how the system here. But for special procedures, I don't know how it is. Whether you have to make the patient pay for some devices. That one I don't know. But for general health care. So coming back to your question, aortic dissection, pray that instructions, but it's a very serious in that requires nothing, no medicine can correct it. The one was the person, but
Yeah,
okay.
yes, boss. Yeah, I'm okay, but we can't see your screen.
Oh, you all
It's
can see my
paused.
screen?
Yeah, you've paused it a long time.
Oh, and you didn't tell me. I was showing you things. Sorry. Can you see it now?
Yes, please.
Sorry.
Because yeah,
Yeah.
I think those also, especially the females with Marfan syndrome also, most of them are encouraged not to even get pregnant. And
Yes. And the
in the
reason is,
case, it can put pressure on how will I even put this? Because of the pressure the pregnancy will exert on the structures, on the body structures, that can lead to a
mhm.
tear on the aorta as well. And
Okay.
those who even discuss with those who even want to get pregnant are encouraged to discuss with their healthcare provider so that they are placed under strict monitoring and observation.
Good.
And even
Good.
in cases where those who don't get pregnant, those who don't inform their prescribers before getting pregnant, sometimes when during the monitoring, sometimes they are even advised to even terminate the pregnancy to save their lives.
Yeah, to save their lives. Yes.
So they tend to
Thank you
have
for
high
that
risk
addition.
pregnancy.
Yeah, that is very, very true. Thank you for adding up. Any other question? Okay. If not, let's carry on to phenylketonuria. Okay. Who has heard of phenylketonuria before? All of us, right? Um, on your dashboard, where do you normally meet this condition?
Pediatrics.
Of course, pediatrics. Yeah.
Yes.
So let's look at this one too. It's also a genetic disorder. Okay. So we are saying, and this genetic disorder, before uh, let's say a child or a baby can get, both mother and father should have a predisposing factor. Okay, before the baby can get. So that is, yesterday someone explained to us what autosomal recessive means, right? So we'll not go there right now, but both of them has, I mean, your mother and father have to get um, the gene before you can get. So it's an autosomal recessive metabolic disorder in which the enzyme phenylalanine hydroxylase, okay, phenylalanine hydroxylase is deficient or absent. This hydroxylase, so phenylalanine is it's the protein-like substance, right? Hydroxylase is an enzyme that breaks down this protein. This phenylalanine is found in most protein foods. Okay, so this is like it's a condition where you lack this enzyme that breaks down the phenylalanine. Okay, phenylalanine is like a protein. I just want to make it simple for you. It's like a protein or a substance found in protein. Okay, when you add hydroxylase, it's an enzyme that breaks down this protein. So people with phenylketonuria, they lack this hydroxylase. I mean, this phenylalanine hydroxylase, they lack it. So what does it mean? It means whenever they consume anything protein, they will have a buildup of this phenylalanine in their blood, which becomes poisonous for them. You look at the clinical manifestations, how they are affected. Okay? So they will have a buildup of this phenylalanine in their blood and they will have issues. Okay, so that is what it means. So the issues normally affect the brain if untreated, as you can see here. Clinical manifestations, how can you see some of these things? So we are saying newborns are usually normal at birth. Okay, when they are giving birth, I mean everything is normal. Okay, but they may have developmental delay, and they can have intellectual disability if left untreated. Seizures can occur, hyperactivity, growth failure, eczema, okay, and they can have skin discoloration in some parts, okay. All of these things happen. Musty, mousy body odor, all these things happen. How do you diagnose this condition among newborns? They are detected through newborn screening, okay. So within first few days after they are giving birth or after they come out of the womb, we do heel stick blood test, okay, after normally breastfeeding them, okay, or if they have they are on any feed, okay. So you give them the feed or you breastfeed them. You don't do it before initiation of feed, but after you've initiated feed, because we just want to know whether the phenylalanine in the blood is getting worse than expected. Okay, so the baby has to start feeding before we can do the stake blood test for the diagnosis. And how do you manage it? If a baby is positive, it means this thing is nothing like something that can be cured. It means the person or the baby involved have to be on dietary therapy for all his or her life. Okay, because even when you grow and you eat lots of these foods that we are asking you to avoid on the right hand side of the screen, you build up phenylalanine a lot in your blood, and you don't have the hydroxylase part, okay, to help convert this to tyrosine, okay, or to break down the phenylalanine in all these things. So you can still have the signs and symptoms of, the accumulated phenylalanine. So the dietary therapy is lifelong. Okay, it's like if you are allergic to something, you don't take it. If you take it, no matter how old you are, you still have allergies. That's how. Okay, so we have if they are still babies, we have special phenylketonuria formula we give to those babies, and you have to regularly monitor their blood levels for phenylalanine level. Very important. On our right hand side here, things that they should avoid. It's here. Okay. And most importantly, this one, they have to avoid artificial sweetener. Avoid artificial sweetener because it contains this aspartame, which also contains phenylalanine. So take note of this aspartame too, or generally maybe artificial sweetener. Any question on this slide?
Hello, sir.
Yes.
Please, I'm a little bit confused. So is it that the phenylalanine contains protein or it's a protein on its own?
So we are saying when you eat protein,
Uh-huh.
okay, so protein contains the phenylalanine.
Oh,
Okay,
okay.
look at your right hand side here. Avoid foods high in phenylalanine. So it means all these high protein foods they contain what? Phenylalanine. It's a protein, it's a substance in protein foods.
Oh, okay. Okay.
Okay, and when you have phenylalanine hydroxylase, when you add the hydroxylase to this one, it means it's an enzyme that breaks down this substance in the protein. So people with phenylketonuria, they don't have that enzyme to break down this phenylalanine. So it makes this one build up. It's like let me link it to kidney disease. When you have accumulation of waste substances in the body and they cannot be broken down or they cannot get out of the body, they become waste in you. Okay, and you begin to have issues. So this one too is like whenever you eat all these foods, you have a buildup of this phenylalanine in you because you lack the enzyme to break this down. Then it will become a poison for you. Are
Oh,
we clear?
yes, please. Thank you.
You're
So,
welcome.
boss,
Yes.
please, the management. There's the last point says we should monitor blood phenylalanine levels. I wanted to know if maybe there's a range for that.
I think if there's a cause for concern, okay. Um,
Okay.
if there's a cause for concern, when we say, let's say, if you are there, like monitor blood levels regularly. I don't think it is every day. Okay, I don't think it's
Okay.
every day. Maybe, can someone give us the range? Maybe how often? But you will not be asked. This one will be very dependent. If there's a cause for alarm, we can monitor. But I don't think you'll be asked like if it's every week or it's like every month or something.
Okay. So I was actually referring to maybe the range, the figures.
The figures. Okay.
Yes, yes. I think
Um.
someone just typed in over there that
Okay.
1 to 2.
Okay. I think I had it somewhere. Maybe I missed it. Okay.
Okay.
I thought I brought it here. All right. Someone shared it with us, right?
Yes, please. Someone just typed
Okay.
1 to 2.
Okay. Okay. So you were
Thank
asking of
you.
the levels. I mean the figures. Okay.
Yes, please.
Thank you. Thank you, Tisha.
Boss, yeah.
Uh-huh.
Boss, yeah. Boss, yeah.
Yeah.
Please, the foods that they are to avoid. The children, they also need these foods for growth
Yes.
and development.
Mm-hmm.
So if you are avoiding these foods, uh,
Mm-hmm.
is it not that we should ensure that even the proteins that they eat are of high quality rather than avoiding them altogether?
Foods that are high. They have, I mean, high in them. We have a lot of foods which have some levels of phenylalanine, which is a bit safer. But foods that are very high, they should not eat.
Okay.
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 Any other
So,
question?
yes, please. So, Boss Gia, does it mean
Mhm.
that their problem starts when from 6 months when they start eating all this type of food, but from 0 to 6 months while they are still taking only breast milk, they don't have issues or they are not even breastfed?
I'm coming again with a question. Mm-hmm.
Okay, I was saying, is it
Mm-hmm.
that their issue starts from 6 months when they start,
Mm-hmm.
adding eating these things? Because from
Uh-huh.
0 to 6 months, we are expecting them to be taking only breast milk, or they are not
So
even
when
breastfed
when
at
it's not
all.
necessarily sorry, it's not necessarily within 6 months, but this thing is being tested. If you wait for about well, um, if you wait for about 6 months before, I saw it somewhere. If you wait for a very long time before you even start testing, you could have, when they are young like that, they can't complain, and when things are happening, you will not see. But if let's say you don't test them, so that's why we test them within few days. I mean, as soon as fees are started, we test them. Because if you don't test them and you don't even have a wider window. Okay, because if you wait until maybe let's say 6 months that you are saying, the damages would have been caused already. Okay, and you will not know when they reach their developmental stages where they are supposed to demonstrate certain things. That's where you can maybe realize this is happening or something's happening. And all that you can do is to protect what is left. But what has damaged, you can't have a control over it. That is how the brain works. So, if I am understanding or if this answers your question, the testing is even done within the very first few days after feeding is initiated. Have I answered the question or you still have?
Ah,
I didn't
but
answer it.
yeah, you have done well. What I'm saying is, you see,
Mhm.
normally babies they don't eat these things. It's only breast milk, normal babies. So I want to
Mhm.
understand these things that we are avoiding. Is
Mhm.
it that the breastfeeding mother will avoid it, or I'm concerned as in
Ah,
as at the
okay.
early age?
Okay.
Yeah.
Okay. Okay. So who can tell us?
I think here when you
Here,
give
when
birth, I think they will test the child for any condition.
Mm-hmm.
So they will know the condition ahead and they will tell the mother, this is what is happening to your child. Don't take this, don't eat this. When your child is growing, don't let her take this or that. So right from delivery, they will test all the conditions there. Yeah. So they will tell you maybe a week or a month. Not in Ghana that we don't test anything. No. Yeah, they will
Okay.
test everything.
Okay.
Please, I want to
Um.
try.
You want to
Okay.
try?
After
Okay.
I want to
Mm.
add something. Carry on. Mm-hmm.
So we were saying that the phenol planning hydro, the enzyme is supposed to convert the phenylalanine to tyrosine or something.
Yes.
So I think that if they are testing if the baby has that enzyme to convert the phenylalanine to
Good.
something something. It's not necessary that the baby will have to start breastfeeding before we will know if the baby has the potential to convert the enzyme.
So look at the left upper part of your screen, the diagnosis, under the diagnosis part. They are saying use take blood tests after protein feeding has begun. So you don't test it before feeding, you test it after feeding. So as soon as the baby is out, you can't test for phenylketonuria. You test after initiating the feed. So let me say this in general and see if maybe it will answer a lot of questions. Do you know that we have adults with phenylketonuria walking around? So let's say for all these things here that you can see on your right hand side of your screen, meat, fish, eggs, yes, they are not supposed to take it because they are very high in phenylalanine. Now let me link it to what our sister was trying to ask. Let's say if this adult woman with this phenylketonuria gets pregnant, if the woman gets pregnant, we will keep on measuring the phenyl alanine levels in the blood. Okay, whilst they avoid taking this, we keep on measuring because they can have effect on the fetus too. So we keep on measuring it. Okay. Yes, and the baby too can be born with it. Okay, but you can't test the baby right after, like right before initiating um the feed. Okay, so pregnant adult women with phenylketonuria, they are managed differently. You still monitor their levels and you make sure that they are not high to protect the fetus and the mothers themselves. Now, let's say the mother does not have, the father does not have, but let's say they all have predisposition or they have predisposing factors and the baby has it. We will still, sometimes in reality, you will not get the mother and the father to test for a lot of things before a baby is born. Okay. Normally, the mother, you can get the mother because it's the mother who normally goes for this visit. How many times do you get the father to test for a lot of things? Unless when absolutely necessary. Okay. So, to cut a long story short, we test everything on the baby. So, if the baby has a predisposing factor, then that is fine. So, all these things that you are saying you have to avoid, it's for, let's say, an adult who have phenylketonuria. That is one. And for a child too, who have phenylketonuria. So they are giving birth earlier, they can't eat meat, fish, and those things. They can't take them. Okay, that is one thing. But what not every baby also takes breast milk. Sometimes mothers will not have breast milk. They will have to be given a formula or something. So whatever thing they are taking, we should make sure that they are nothing. There's nothing like artificial sweetener or aspartame. Okay. So as soon as we give them food and we test them and they are positive, we are careful about all these things that they shouldn't take it for the rest of their life. Okay, but they can take foods. You can't avoid them to prevent phenylalanine like 100%. These are, like I was saying, these are foods very high in them, and you have to avoid. Okay. Um, we have beans here, even beans too. Okay, beans and nuts too. Peanuts, yeah, and all of, okay, nut is here. Okay, they have to avoid. All right, they can take in, like, I think almost every fruit and vegetable is fine for them. Okay. Um, look at potatoes. Potatoes have some kind of mineral, but it's not too much, but they can take it. Okay. And some bread, bread also has some kind of protein, depending on the ingredient that was used to do it. They can have it. Okay, they can have protein in it, but you know, they can take it. Okay, so they can take, some other things which also contain phenylalanine though. But these foods we've mentioned here, they are very high in it, so they should not consume. Any other question?
Can they take milk and cheese?
Milk and cheese. Um, Milk is high in no, they can't take milk and cheese. Yes, they can't take milk and cheese. Um, so cheese is coming from, look at the dairy product. Cheese and milk, they are all part of our dairy product here. Can you see it? So they can't take it.
Yes, please. Yeah.
Very high. Yeah.
Yeah.
Okay. So that is it. Um, well, should we do
Hello,
this before we
yeah.
go? Or we should go?
Hello, please, I want to contribute.
All right, thank you.
In the U World Book, I saw this formula foods that can be given to the infants. They call it Lofi Nala.
Oh, okay. Okay, for babies with phenylketonuria.
Yes, please.
Okay, thank you. Thank you for adding that. Any other question?